today, leading the questions will be Dr. Rena Pasick. She's with the University of California, San Francisco, and is a co-leader with us in Éxito, and also the leader of the MTP-CCR program. So she will lead the interview with Dr. Green. And so now, Dr. Pasick, if you will please start the interview with Dr. Green. Thank you so much, and I hope you all enjoyed our program today.
Thank you very much, Amelie. For those who are in MTP-CCR, you may remember that on the first day of every Summer Institute, I begin with a card that was sent from one of our first participants, a young woman by the name of, it escapes me right now, actually. Her card had on the front, "I deserve the very best." And inside it said, "Thank you for understanding that." One of the things we have always strived for at MTP-CCR and Éxito is to give you all the very best because you deserve it. And today, perhaps more than any other time in the history of this program, we are bringing you the very best we possibly can. One of the great leaders in the field of community health, as Amelie said, Dr. Lawrence Green. Many of you probably know him best by his work on the Precede Proceed framework, which has been described as the seminal embodiment of the concept that social and behavioral influences are keenly interrelated. There's so much more to his incredible career, but I'm going to very, very briefly hit on some of the highlights. Dr. Green has had professorships in public health at UC Berkeley, Johns Hopkins, Harvard, Texas, University of British Columbia, and UCSF. He was the first director of the Federal Office of Health Promotion, where I had the privilege of meeting and working with him many years ago under the Carter administration. And he served as vice president of the Henry J. Kaiser Family Foundation. He has published several books and over 300 articles on program planning, evidence and evaluation, issues in health services, public health, and health policy. And his prestige is further demonstrated in such honors as having served on the founding U.S. Preventive Services Task Force, now the Task Force on Community Preventive Services, and he's associate editor of the Annual Reviews of Public Health and on editorial boards of 13 other journals. If someone were to accuse me of hero worship when it comes to this man, I plead guilty. And I just want to share with you this cartoon that shows Larry as I think of him and see him. So, without further ado, I want to welcome you, Larry, and it is my great privilege to be able to, you're blushing a little bit, I guess I did the job here.
Who wouldn't?
So, do you have any opening remarks that you would like to make?
Well, excuse me, Larry, before you start, Rena, you need to share your screen.
Oh.
Share your screen.
I think is that the one? Did that do it?
All better.
What?
All better.
All
yes.
better? Okay, sorry about that.
Well, thank you, Rena. Yes, I'm blushing, and but I'm also relishing the years you've covered with that introduction, and especially the ones where we've had the opportunity to collaborate as colleagues at UCSF particularly, but also during that period in Washington, D.C. with the Office of Disease Prevention and Health Promotion. And you were, at that time, what I will advocate in today's discussion, an intern in a federal agency. Not that federal was critical. I think it was the idea that you were out of your academic nest and into a practice setting, working with people who are struggling with real problems in real populations, and putting some distance between yourself and the textbooks that abstract these things. And that's what I think we really want to talk about today. So it's been a pleasure also to work with you here at UCSF. And so we know where to go wrong, at least, and we'll see if we can make that happen today.
Oh, that's pretty easy. Okay, well, let's get into it. We're going to do an interview format, and then, as Amelie mentioned, you will all have the opportunity to post questions for Dr. Green near the end of this session. So, my first question. You have famously written, if we want more evidence-based practice, we need more practice-based evidence. What does that mean, and how did you arrive at the statement?
Well, I think I can take those two questions in the other order, because how I arrived at it probably best characterizes what it means in the way I'm using it. In the early 70s, when I was an assistant professor at Johns Hopkins, after my Berkeley experience, I encountered a literature that was mainly behavioral sciences when it came to research. And when I queried with NIH why there wasn't more applied behavioral sciences research, what I found was that NIH at that time, late 60s, early 70s, had only one behavioral study section, and that was a physiological behavior study section. And they were very committed to funding research that was physiologically based and depended on randomized controlled trials at the physiological level. What happened then, fortuitously for us, was that Robert Levy, who was the head of the National Heart, Lung, and Blood Institute, initiated the National High Blood Pressure Education Program, one of the most effective NIH-driven programs of the 20th century if you use reduced mortality as an indicator. What happened to them in trying to implement that National High Blood Pressure Education Program, getting people to submit themselves to blood pressure measurement and if elevated, submit themselves to blood pressure control activities. What happened is that they recognized they didn't have very much research to go on related to the determinants of behavior, all of the reasons why patients wouldn't go for a blood pressure check or wouldn't go to the doctor, and if they went to the doctor, why they would seem to be very averse to complying, as the term was then, adhering to their medical regimens, taking their pills and following the other advice. And so they mounted for the first time an announcement of grants available to do research on this subject. And we at Hopkins got one of those grants and found ourselves in what seemed like enemy territory, usually when we made the trek to Bethesda to talk to people at NIH. They had a hard time grasping how we were going to study these things with respect to real people and real populations in real time. And so that began to cause me to question the very model that characterized most of their research. That's a model that has been emblazoned since then in what is called evidence-based medicine. And that has been the systematic review of studies that used randomized controlled trials and the accumulation of that evidence to prescribe best practices, or what has come to be known as evidence-based practices. And the public health, we in public health have tended to draw heavily on evidence-based medicine and import even their methods of reviewing the literature, so that we screen out of the literature much of what would be most relevant to us. That is, trials and studies and program evaluations that were not randomized because you couldn't randomize people in those population settings. Ethical restraints and realities on the ground limited how much you could randomly assign people to study populations. And even if you could, and here comes the rub, even if you could randomly assign people, you were creating conditions that were unrepresentative of the settings in which the results would be applied or taken to scale. And so that's what over time has caused me to continue to work with systematic review groups like the Community Preventive Services Task Force and the Cochrane Collaboration and others, but to become increasingly dubious about doubtful about the evidence that we were left to work with after we screened out all the studies that didn't meet the criterion of randomized controlled trial. And so I dug deeper into the literature that I remembered from my coursework in evaluation, having to do with internal validity versus external validity. And what I realized is that all of the criteria that NIH uses in screening the grant applications and all of the criteria we use in reviewing the evidence for best practices, based guidelines, tended to be very strong in internal validity, but very weak in external validity. And so what I began to push for when I was at CDC as director of the Office of Science and Extramural Research was the complementary role for CDC in funding community-based research that would produce more practice-based evidence rather than duplicating the evidence-based practice that we were getting from NIH. So that's the story, how it emerged and how I became committed to it. And it was there at CDC that I coined this phrase that'll probably be on my tombstone. If we want more evidence-based practice, we need more practice-based evidence.
So this story reminds me of something I wanted to say in my introduction, which is that one of the many things I love about Larry is that he is an encyclopedia of history in public health and community health. And by hearing these kinds of stories and this background, which I did not get out of things that I was reading or even my education that I can recall, it helps make sense out of what we have to work with today. And not only, as you can see, has Larry retained all of this and can give it back to us in a really meaningful context, but he's had an incredible influence on that history as well. So building on what we've just discussed, for this particular audience of Exito and MTP CCR folks, what are the implications of evidence-based practice, practice-based evidence for health disparities?
Well, I think we pick up on the strand of my previous comments where I point to the problem of external validity, that is, the representativeness of the evidence that's produced by highly controlled studies. Its relevance then to the populations that don't get well represented, the populations that are often screened out of the studies or that the studies never reach because they are conducted under circumstances that only reach a more affluent or a more homogeneous white population. And that's why I think much of our so-called evidence-based practice often lacks applicability to minority populations, ethnic populations. Rena, you did some very fine work that we got you to publish in the Annual Review of Public Health on the applicability of our theories to other cultures. Well, the same things that you pointed to with respect to problems of theory not having applicability apply to and probably derive very heavily from the problem of the evidence not being done that produced the theories in those populations.
So, what are the implications of these challenges and limitations in our field and our body of evidence for our program alumni with new doctorates in public health?
Now, will they all have, they wouldn't all have their new doctorates when
We
they come
have
in.
many, actually, who have graduated with their PhDs now. I want to say around 200 have gone into doctoral programs, and about 100 of those have graduated with their doctorates. And that was before we tallied the results of our current and recent alumni survey, which we're working on now. Don't forget to fill out your alumni survey. So yes, we have, actually it would be great if you could speak to the different segments of our alumni, those who have graduated, those who are in doctoral programs doing their own doctoral research, and those who are practitioners at the master's level, but have been exposed to research, at least in as much as they participated in our program.
Well, let me try to approach that subject from the standpoint of what needs to happen with the programs, the academic programs that people are enrolling in or graduating from, in order for it to serve the needs of producing evidence, practice-based evidence. I think that your PhD graduates will probably have been deprived of the opportunity to spend much time outside their studies, their carefully controlled studies, often for their PhD dissertations. The DRPH graduates are more likely in the past to have been required to get some experience if they didn't have a lot coming in. And so the rotation of the DRPH students into practice settings where they can learn leadership skills and the realities of practice probably served them well. And you and I both did our DRPH degrees at Berkeley, and I think, I hope I can safely say you got some of your experience, early experience there. Now, this isn't to disparage the PhD, and I'm confident from having participated in some of the accreditation discussions of new guidelines for DRPH programs that there will be assurance of getting the students to rotate out of the Doctor of Public Health program into the field and back, and building their dissertation on that kind of field exposure, community exposure. What I think the PhD graduates should seek, if they don't have it, and many of them would have probably, they probably were required to have some experience coming into their doctoral degrees, are opportunities to step out of their doctoral studies, their academic studies, into the community to see whether the subjects they're interested in are being applied, affected the way their theories and research would suggest they should be, and why not if they aren't. So that's the first recommendation, is to either get that kind of experience before you enter a doctoral program, or seek an opportunity to step out of your doctoral studies at the point you think you know from the literature what's going on, and you want to go out and verify that that's what's happening. One other thing I'll say by way of recommendation is that you ought to look for opportunities in your coursework to dig deeper on the questions of program evaluation. Don't simply rest on guidelines from research methods courses that present you with the ideal research designs. Ask about the quasi-experimental designs, and beyond that, the designs that would suit the study of ongoing real-life programs to evaluate their effects. And that's often not going to be randomized controlled trials.
So what I'm hearing is that researchers and research both need the same thing, which is intensive exposure to the real and engagement with the real world. I read two of your papers today, kind of side by side. And by the way, you all have a number of things available to you on our websites that include a list of Dr. Green's publications. And I read two of them, one from 2001 called From Research to Best Practices in Other Settings and Populations. And the second one was called Turnstile Careers Between Academia and Practice. And even though the first one, Best Practices, and I'd like you to talk a little bit about that term and your take on that term. Even though that paper is from 2001, for me it was like a cool breeze blowing across the desert. It was so relevant to what I'm doing today, and I need to go back and really just sit down with that paper and commune with it closely, because and I obviously strongly recommend it to all of you. It really validated what we're trying to do in my own research, what we're advocating when we work with our summer institutes and our internships, of trying to knit together this world of, for want of a better way to put it, internal and external validity. The kinds of methods that were taught in epidemiology and clinical research, and what we hear from people like Marjorie Kagawa-Singer, and those of us, the leaders in mixed methods research. And then here's the paper on turnstile careers, and I'd like you to define that term for us. So can you further elaborate the relationship of these concepts and what they mean?
Yes, thank you. The first of those, the From Research to Best Practices in Other Settings and Populations, was my first real gunshot across the bow of NIH and the field of public health education, health promotion, and public health practice in general. And that is, if we keep feeding you from research and you keep trying to apply it in practice or in policy, we're in a trap, we're in a pipeline that has been characterized by NIH as moving from their conception of what kind of evidence is needed down this pipeline through increasingly squeezed interventions on what flows through the pipeline by peer review processes in grant applications by systematic reviews that lead to guidelines for best practices. If we keep pushing through that pipeline, it becomes a funnel that squeezes the life out of the research to the point that what drips out at the end of the pipeline for practice is highly refined and, I regret to say, often irrelevant to, or at least not a good fit for, a lot of practice circumstances and populations to which it would be applied. So that was the problem I was struggling with in the first paper. Over time, as I've fought that battle on internal versus external validity, on how to make research more relevant to practice, how to engage communities in helping us set the research questions and the research methods to fit their circumstances through participatory research, for example. How to interpret the research with a more generous inclusion in the systematic reviews to produce guidelines for best practices. And then how to take the evidence to scale, or how to put it into practical guidelines for program planning and practice, the implementation process, and ultimately the evaluation of how that all plays out at the end of that additional pipeline. That's how the first paper has played out and has been massaged over the 2 decades since it was first published. The other paper, the Turnstile Career paper, is one that I've only just recently published, so it hasn't stood the test of time yet. But it grew out of a notion I was nurturing of revolving door careers. And one of my former students, Barbara Reimer, who's now the dean of the School of Public Health at the University of North Carolina, called me up on the use of the term revolving door careers, because it's been a term used for people who were leaving government to take up consulting positions for for-profit organizations that would be using their inside government knowledge to get contracts and influence policymakers. So the term turnstile careers was a substitute for revolving door careers, and I think it's got a better fit for what I'm trying to describe. And that is that what I would recommend for all of you who are getting your careers launched is to look for the opportunity when you take your first position in academia or in practice or policy, for an opportunity to rotate for a sabbatical or a leave of absence for a period of time on the other side of that divide, to spend some time in real-world settings, government or voluntary agencies or community organization groups, and to understand more thoroughly from those exposures what it takes to put the evidence into practice. And if you're already in one of those settings, take a break and sell your services to a school of public health to come over to the other side and inform the faculties who haven't had those experiences to understand better what's needed in the field.
So we have an environment where the real world has sort of been squeezed out of the evidence as it has funneled its way through the path that you described. And yet we're admonishing people to put evidence into practice. For young professionals, both who are researchers and who are practitioners, we're sort of putting a burden on them, I think, or challenging them to push back when they're asked to do these things, to toe the line, whether it's in research or practice. So what advice would you give, particularly to our alumni who are working in underserved communities and for whom the evidence, may be less relevant than it is even for a more general population?
Well, I think that you've put your finger on the problem and the solution. I think the problem is that we've been force-feeding evidence-based practice that doesn't fit. And we have been insisting, as part of that problem, that they implement the evidence with fidelity, with all of its moral overtones. If they don't do it the way the guidelines said it should be done based on the highly controlled research, they are somehow sinful. I think what we have to do is loosen up a little on those insistences on evidence-based guidelines when they are applied in settings unlike those in which the research was done. And the settings will almost always be unlike where the research was done, because the research is never encompassing of all of the populations in which it might apply. And then we have to encourage adaptation, not fidelity to the original guidelines, but adaptation to the population in which it's being applied. And that can best be done through a participatory process of engaging the community and helping you understand how their situation differs from the situations where the research was done. And then third, and this is the last, at least for the field, we need to evaluate the adaptations. We need to carry forth the same kinds of studies that were done originally, but with greater flexibility to fit the community and with a sincere effort to evaluate whether we're getting as good a result or better result than the original studies. And so evaluation becomes my latest return to my roots. Evaluation is the key to practice-based evidence.
So I've written down this quote, Lawrence W. Green, DRPH, on January 11th, 2017, said, "We need to loosen up on evidence-based guidelines." I don't think you've written that or published that exactly. Huh?
I don't want to get shot.
But we have it, we've recorded it, and I think that that is an incredibly important statement. So I just want to shine a light on something that I keep seeing as I work with my young colleagues, and that is a heavy reliance on the internet and what they can find searching key terms when they want an intervention, when they want some literature backup, or anytime they have a problem or a question, they are turning to whether it's Google Scholar. But I have the sense that we're living in a Yelp-oriented, they want, I don't want to say they, because I do it too. We want something straightforward. We want to see ratings. What's the best intervention for this problem? What comments do you have about that?
Well, I think the best thing that has happened since I started this tirade is that more and more attention is being given to translation science, implementation science, dissemination science. And those, dissemination and implementation is now the title of a book authored by, co-edited by Ross Brownson and Enola Proctor and Colditz at St. Louis, at Washington University in St. Louis, and they're about to come out with a second edition. I think that's the best compilation right now of guidance to what to make of the literature as we receive it, and how to take it to the next step of vetting and testing, applying, how to disseminate it sensibly rather than as tablets on stone. It really has to be further field tested after it becomes evidence-based practice. And that field testing will make it practice-based evidence.
Does this book, or are there other works that you can refer us to, touch on how to assess external validity in a given context? And I don't know if you have, in the course of this conversation, defined external validity. And if you didn't, then maybe we should just do that before you answer that question.
Well, the way I'm using the term and the way it was used originally by Stanley and Campbell in their original work on experimental and quasi-experimental research, and since then by Shadish, Cook, and Levinton and others, is the degree to which the study design provides for the results to be generalized to other settings, populations, and units of populations. And that's how I think it's been most formally defined and how it continues to be used, perhaps more loosely at times. And what I've tried to do in my chapter in the book by Ross, Colditz, and Brownson is to answer the question you just posed. What is external validity for purposes of research in health, public health in particular? How can we improve upon our assessment of external validity when we consume the literature? And how can we adapt the interventions to make it more appropriate to the populations in which we would apply?
That's the paper I've been searching for all these years. One of the things you mentioned in something that I read was that the nature of our publications is such that we're not able to detail all that went into our intervention studies or the interventions. And so when one wants to assess the applicability of an intervention, or they want to adapt it and evaluate that, they don't have all the information they want.
Well, that's been another path that I've pursued with, particularly with a colleague, Russ Glasgow. And what we did about the time that I was coming out of government service at CDC was to convene a group of editors and ask them, why can't you provide more space for rich description of the interventions? What gets cut first when your paper is too long? It's a lot of the description of the intervention. And what gets cut second? A lot of the description of the population. So what you're left with is a recipe book for interventions that doesn't tell you what the kitchen is like and who's going to be eating it when you're finished. So that's, and there is one unit at NIH that has taken this issue up very sincerely, now headed by David Chambers. Actually, Russ Glasgow was the head of it for the time. David Chambers has carried on in the production of an annual conference now on dissemination and implementation research, and they're addressing some of these questions. It was an annual training program that we took around the country with a mixed faculty of those of us concerned with these issues. But now they've decided they don't need to take it out. There are enough people interested. They'll come to Bethesda to take it to the annual conference. Have you gone to one of those?
I've been on the faculty
Oh,
of one of them.
okay, great.
Yes, so I think that is something that we try to push out notices of those kinds of opportunities to all of you when they come up, but this is a particular case of something that you should really be looking for because it is a great experience and it really helps you see what a lot of the great minds are doing today in terms of dissemination and implementation. And I think there are other training programs now that are being funded through the R25 mechanism, kind of regionally around the country, that are taking up this issue of dissemination and implementation. So you all should definitely take advantage of that. I think we are exactly at 12:45. I feel like this has been such a tease. I wish we could have a whole afternoon, a day, a week with Dr. Green, but I think that we've given you a sense of his wisdom, and there's a lot more in his writings, but now is your chance to ask questions through the remainder of this webinar. And Kip Gallion, it was my understanding that you were going to read off the questions. Are we still on that, following that plan?
That's correct. At this time, we have only one question. I hope more will be forthcoming. But the current one is, what is the structural issue that perpetuates the evidence-based pipeline, and what are the benefits or convenience being protected?
Beautiful question, and it's one that I have tried to address in one of the papers, not these two papers, but one that's titled, If It's an Evidence-Based Practice, Where's the Practice-Based Evidence? And in that paper, I've drawn the funnel. I've also used it in this chapter in the book by Brownson and Proctor and Colditz. It shows what happens as data evidence goes through the pipeline, what's happening to it with respect to peer review and the screening of studies eligible for systematic reviews, and what happens to it between systematic review and guidelines and so forth. At each of those steps, there are things that can be corrected in our systems of data vetting, but there are things that also need to be understood by practitioners using the evidence when it comes out at the end of the pipeline to understand what's happened to the evidence that might make it more or less relevant and appropriate to their circumstances. Some of the interests that are being protected, to your point, are academic promotion and tenure, professional control over what practitioners do, the reimbursement of practitioners for practices that are reimbursable but often not done appropriately according to guidelines.
Peer review.
Peer review is not being protected so much as being one of the things that we've got to break through in a way.
Okay.
You know, what happens in peer review, it's a phenomenon I've observed sitting around the table for peer review, where the primary reviewer tells us what he or she thinks is wrong with the study being proposed. And then a secondary reviewer, who is often a younger colleague, academic, wants to prove how rigorous he or she is. And they go after tooth and nail, nitpicking the study. And a culture, a more rigorous than thou culture sets in. And by the time that study has been discussed around the table, it's been shredded. And it might have been the very study we need, but because it didn't meet all of the standards of internal validity, for example, it gets shot down. So that's an example of how the system is protecting itself and its participants. It's the way that peer review is probably not serving us as well as we might wish. And I don't want to give up on peer review. I just think we need to manage it with a little more caution.
My experience with peer review and these kinds of issues, when I write a grant and I get that kind of pushback, I am reminded that I use the expression, reviewers are not gazelles. We can't expect them to make leaps conceptually or methodologically. We've got to take them by the hand and walk them step by step through our thought process of why we are proposing what we're proposing. And in my case, it's usually I'm trying to ground my research through a more inductive component that's qualitative, and I'm always doing mixed methods these days. And as the foundation for that is the fact, can be stated with taking up very little real estate on the grant page, that the evidence that exists does not necessarily apply to the population I'm concerned about, and so I need to go back and in a really deep kind of way understand the community, the setting, the context. You've got to lay this all out for reviewers, and when you do that and you show them the questions that are not yet answered that your approach is addressing, I think you'll find a better result, and you do get an opportunity to reply to a review, to a grant review, at least in NIH proposals.
Let me pick up on two of the more hopeful lights you've cast on this. One, I think the problem you started with, Rena, of inadequate description, rich description of the intervention so it could be replicated or adapted in another community. What the journals have conceded is, yes, we understand this is a problem, and we will provide space on our website. The journal now has a website, usually, where you can put some supplemental materials, such as rich description of the intervention. The other problem that we're touching on here is that of I've lost it now. I had too many things going on there. So
I know they're
next
feeling
question.
I'm having the same problem.
We have another question, since you've been... many organizations adapt evidence-based programs to other populations, such as Latinos. Instead of being able to build on those efforts of like-minded researchers across the U.S., we are often called upon to repeat that process. Do you have any insight on how to be able to advance adaptations of similar work? Well,
now that brings back to mind the other point that Rena was making. I wanted to expand on. What she was describing is a method, process she goes through in adapting theory and evidence to a new situation that you're working in. And the use of alternative or complementary methods to do that. The process of adaptation calls upon more data that you might be able to collect at the local level, and it requires, or it might benefit from, more qualitative data. And there was, for a long time, a running debate at NIH on qualitative versus quantitative research. But over time, I think that's been resolved at NIH with the term mixed methods. And that's where I think we have the opportunity to do a lot of this adaptation work.
Good. We have another question. Do you have any advice about when or how to bring payers into the research process so that they don't derail effective practices, yet at the same time they are involved so that successful programs are adopted by payer systems instead of collecting dust on a shelf?
Well, I think the answer to that question lies in politics and policy influences that we can seek to have with the publication of our work and the dissemination of our work to policymakers. But probably more than either of those, collaboration with policymakers in doing the research that answers the questions they're struggling with on how should we reimburse this activity, or how should we fund the, the range of alternative interventions that might be pursued when we turn out a block grant to the states, for example, from CDC. They have to give guidelines to the grantees who will accept these funds, usually state health departments, who will send the money on down to local health departments. And their guidelines are usually based on the evidence they have, but they can also be based, should be based, I think you've heard me arguing throughout this, on a commitment to evaluation of whatever they do so that we can see whether or not they're getting the results that they intended. So those are the avenues I see for influencing policy. And the policy makers, I think, include Congress and the agencies that administer the funds that Congress gives them for medical or public health interventions.
Those are all the questions that have been posed to us, and it's almost 3 o'clock. Raina, do you have any further questions, or do you want to wrap this up for us?
Well, I just want to say that, funds for the kinds of things we want to do, we in the Exito and MTP-CR family, which now numbers over 600 people across the country. The things we want to do, funds for these things, are going to be are precious and probably going to be increasingly precious. And we really have to make the most of funding opportunities in terms of that come to us, that we seek out, that we're fortunate enough to acquire. And the purpose of all this today, to bringing Dr. Green to speak to you, is that we want your work, whether it's in research or the practice of public health, we want to get the biggest impact on the health disparities that we are trying to eliminate. And the bottom line here is that we need to do that by joining forces, researchers with practitioners and practitioners with researchers. And all of these concepts and ideas and history and advice sort of boil down to that, to grounding research in real-world problems and solutions that can be found through the wisdom of community leaders, community members, and practitioners. And practitioners need to align themselves with research because they have so much wisdom and knowledge that needs to fuel the research process and inform the research process. So that's what we're all about in this webinar. And I want to give Larry the chance to make a closing remark, and then I'll have an editorial comment to make.
I don't think I could say anything more beautifully than what you just said. Thank you.
Thank you. Well, thank you so much, Larry. Thanks to Kip and Amelie for making this possible, and thanks to all of you for participating. And here's my editorial comment. Our country is embarking on an unprecedented time of turmoil and uncertainty, the effects of which will no doubt fall most heavily on the vulnerable communities that we are all concerned about. We didn't know about it. We didn't know this when we started MTP and Exito, but as I look back from today in January of 2017 and what is happening, I realized that what we were doing was disaster preparedness. The disaster is upon us, and it's going to continue for a long time to come. You are the future leaders, the guardians of equity and health. And you will not be able, you will not have the luxury of taking a comfortable path. We need you to strive for the highest level of influence that you can attain and to work your heart out for the communities that we all care about. We, this generation, are coming and going, but stand on the shoulders of giants like Dr. Green. He has abundantly provided for you in the many pages he's written. This little tiny taste of knowledge that he gave you today is out there at your fingertips. Please take advantage of it. Don't reinvent the wheel. But our hopes and prayers are with you, and as Barack Obama would also have us say, hope alive. Thank you.
Thank you very much, Dr. Pasek, and thank you very, very much, Dr. Green. That was a great session. I'd just like to remind everybody you're soon going to get a survey. Give us your feedback on today's presentation and future presentations you might like to hear. And be aware that this webinar will be available online on our Exito website. Give us a couple days, but if you'd like to hear it again or point it for other friends and colleagues, it'll be there. Thank you again. This concludes our webinar.